Okay, let's get started with volume depleted prerenal AKIs. Again, we're in hypoperfusion. In volume depletion, you really have a low amount of volume in the system, and that's what leads to the acute kidney injury, thus hypovolemic in nature. So this can be due to multiple problems like low intake or dehydration, renal losses, and this could be osmotic diuresis due to DKA. In response to your body being overfilled with glucose and DKA, what happens is there are sodium glucose cotransporters in the kidney, and that's what actually will cause, in order to make your glucose normal, you have to deplete the glucose in the blood. And so it will actually take the glucose out of the blood and then put it into the filtrate in the kidney. And this actually will cause water to also cross over and cause osmotic diuresis. Another common cause is diuretic use. And then we have extrarenal losses such as gastrointestinal disease, burns, and blood loss. Another good example of this is diarrhea. If you guys remember me teaching you about diarrhea, a lot of those patients had elevated BU into serum creatinines and were dehydrated. And then third spacing due to crush injury or skeletal fracture. This is where the body really makes fluid go into that third space due to an injury. And this thus causes volume depletion throughout the rest of the body. Some drug-related causes, you can see here, these are all types of diuretics. So you have osmotic diuresis via mannitol, thiazides, which you guys should have been familiar with from renal. Loop diuretics, again from renal. Renal, you guys should be familiar with. Potassium-sparing diuretics. Carbonate hydroxylase inhibitors, once again, renal maybe taught you a little bit about these, but we also talked about them in the acid-bases disorder. And then SGLT2 inhibitors may be an agent that you're not as familiar with. These are sodium glucose cotransporter 2 inhibitors. What they do is they actually will stop, or they will actually, let me try this again. They actually will stop the reabsorption of glucose in the kidney and cause increase in glucose diuresis. That's how they work as anti-diabetic agents. You can always remember these guys by cangliflozin, digliflozin. They all have the gliflozins at the end of it. And it's canagliflozin, dapagliflozin, empagliflozin, and nortriptyline. I apologize. This is actually Jardiance. The patient presentation actually should be very much reviewed for you all. You have patients with a history of renal and extrarenal losses and increased thirst as their general complaints. Physical exams, hypotension with resting tachycardia, poor capillary refill times, dry oral mucosis. Again, all things that we learned in our hypervolemia session in fluid and acid base or fluid balances lectures and acid bases lectures. And then if the patient does have blood loss, you'll see hemoglobin and hematocrit decrease. You may see an acidosis or alkalosis, and then electrolyte disturbances. To treat, obviously, fluids will play a big part. You do want to make sure that you stop any secondary causes, giving therapy for diarrhea, for example, stopping any drug-related causes, stopping bleeding. And if there is a crush injury, often it will require a surgical intervention. In order to fix hypovolemia, we give volume. So you'll want to do intravascular volume depletion. If it is severe, you want to use crystalloids or an IV. But if the patient is able to tolerate oral therapy and can take in fluids by mouth without vomiting and can tolerate it, then we will try to use PO fluids. You only get blood if the hemoglobin is less than 7%. Our next section is hypotension. These are really your shocks. Whether it be sepsis, usually due to an infection causing septic shock, anaphylactic shock, such as whenever you have a severe allergic reaction, or a neurogenic shock where a head injury or trauma typically will cause your sympathetic nervous system to stop reacting the right way. Usually these patients have acute mental status changes. If they have a septic shock, they'll have fevers and chills and weakness and fatigue. Because they're not perfusing appropriately, they'll have cold and clammy skin or pale and ashen skin. And in order to overcome the lack of blood oxygen, they'll be tachypnic and have hypotension with or without tachycardia. Their lactate may be elevated, especially if it's sepsis. I did bold some of the big things that I wanted you guys to know. For treatment, so hypotension and hypovolemia do have several things that are in common as far as treatment. And a lot of our patients that are hypotensive will also be, or lots of our patients that are hypovolemic will also be hypotensive. But some things that are in common is that we do want to make sure that we treat the underlying cause and give crystalloids. Even in patients that may appear to not be hypovolemic but are in a state of shock, you do want to give crystalloids. The idea here is that you want to make sure that you get plenty of fluids prior to giving vasopressors in order to avoid ischemia. It's one of those ideas that you fill up the hose before you clamp down on the sides of it. Your vasopressors can be given as second-line therapy. This can include things like norepinephrine, vasopressin, dopamine. Epinephrine is also a good example, especially in patients with anaphylactic shock. We give epinephrine. And then if it is chronic, we can try one of these two agents, midodrine, which is a alpha-1 receptor agonist, or fludrocortisone, which is a mineralocorticoid receptor agonist. It's a type of steroid as well. Next, we have our adenomystate. These are types of hypervolemia. So what happens here is that your heart stops working the appropriate way for some reason, at least in the case of heart failure, or there's just third spacing due to volume overload. It does seem kind of crazy after talking about giving fluids in these top two that the treatment here actually would be diuresis. So what you see here is you'll have conditions such as whenever you have reduced cardiac output and cardiogenic shock, congestive heart failure, chronic kidney disease, and chronic liver disease are common disease states that you'll see that the patient may have adenomystates that cause AKIs. Now, when we think about when we think about heart failure, and let's just take a moment here so we can define something here. You can think of your heart, your liver, and your kidneys as a three-legged stool. Let me actually draw myself a little three-legged stool. If one leg goes, the other two tend to suffer or tend to not fall too far behind. So whenever it comes to patients with congestive heart failure, they can develop chronic kidney disease, and that is called cardiorenal syndrome. Also, you can have patients with liver disease that start having renal disease, and that's hepatorenal syndrome. So I just wanted to define those two things for you as well. In edematous states, of course, these patients will be hypervolemic. And the signs and symptoms of hypervolemia are very similar. Shortness of breath, to what we've learned before. Shortness of breath, dyspnea on exertion, leg swelling, and rapid weight gain. You also see the patients may have pulmonary edema on physical exam, hypotension, anasarcia, which means that they have fluids everywhere, ascites, fluid on the stomach. Specifically, this happens in liver disease. Orthopnea and dyspnea. So orthopnea is where when you lay down flat, you feel breathless, and dyspnea is just the feeling of breathlessness, and then rapid weight gain. You may see an elevated BNP, and that could be a sign of edematous state. What we'll do to treat edematous states is to give diuresis with a loop diuretic. Now, if the patient has underlying liver disease, we'll give a loop diuretic with a potassium-sparing diuretic. Now, patients that have long-standing CHF, CKD, or liver disease who are on long-term diuretics may start developing what's called diuretic resistance. And it's just that the patient no longer responds to the diuretic dose that we typically give them. Well, how we do this and how we can manage this is we can start giving a higher dose of diuretics. So this would be a patient that's already on diuretics. One interesting thing about the pharmacokinetics of diuretics is once you start getting a response to a diuretic. So if you are creating urine or extra urine while you are taking your diuretic, It's actually been shown that increasing the diuretic dose doesn't increase the amount of urine as much as increasing the frequency of the dosing. So that's why increasing frequency may be key. You can consider IV therapy because in patients who are edematous, you'll also get what's called gut edema. So if you remember, your stomach is filled with villi. So those are those finger-like things that help absorption. And those villi have little microvilli on it. And you can think to yourself that that's because you want to have increased surface volume or surface area. Whenever the gut gets edematous, however, those little microvilli will start filling in, and the surface area starts decreasing. For that reason, often IV therapy can be more beneficial. You can also consider adding a thiazide diuretic such as metolazone. Now, metolazone should be given 30 minutes before you give the loop diuretic for a better synergistic effect. It is notable that other thiazides, including chlorothalidone, can't be used in patients with creatinine clearances less than 30. Another consideration could be giving a potassium-sparing diuretic such as spironolactone, eplerenone, and any of these other agents such as triamterene. Our final list of the final list on our list of etiologies is selective renal hypoperfusion. This is where the hemodynamics of the kidney cause a decrease in perfusion or hypoperfusion. This could be due to vasodilation or vasoconstriction, or this could be due to a blockage. We're going to start out with bilateral renal artery stenosis or unilateral stenosis. Now, your body has two kidneys. If you have one kidney with renal artery stenosis and your body has two kidneys, you typically don't have any symptoms. So you need bilateral renal artery stenosis if you have two kidneys, and then only unilateral if you only have one kidney. And there are patients that have only one kidney. What renal artery stenosis is a narrowing of the renal arteries and their branches leading to impaired renal function. So instead of having good perfusion to these kidneys, it starts becoming narrower. And typically the reason for this is atherosclerosis or the buildup of plaque because of high cholesterol. And now if you think about it, plaque can build up in multiple different places in your body. And I'm sure you guys have learned about this in your hyperlipidemia knowledge in cardio. So it could build up in your heart vessels leading to MIs. It can build up in your carotid arteries leading to a stroke. In the renal arteries, this narrowing causes acute kidney injuries. And this is very common in patients that have atherosclerosis in other parts of their body or other risk factors for cardiovascular disease. Most of these patients don't really have specific symptoms that lead them to coming to the hospital or to the doctor's office. They may have hypertension that is resistant to medical therapy or early onset hypertension, like in their 20s and 30s. They usually have worsening of their renal function whenever they get started on an ACE and ARB for their treatment of their hypertension. And usually this hypertension is resistant. Another notable sign and symptom is flash pulmonary edema, where the patient will all of a sudden have fluid on their lungs. In the labs, we'll see protein in their urine, and their diagnosis really is based on imaging with a renal ultrasound. So, whenever a patient has renal artery stenosis, you have three therapeutic options. 1, medical therapy alone. 2, percutaneous renal angioplasty. That's where they will go into the renal artery and open it up, usually with a stent. Or surgical revascularization, where they take an artery from some other part of your body, such as in your leg, known as the saphenous vein, and put it in the renal artery to keep it open. Now, if they do decide for medical therapy, and this is going to seem a little counterintuitive, and I apologize, one of the therapies is ACEs and ARBs. Here's the reason. When patients have AKIs due to renal artery stenosis and they start an ACE or an ARB, it typically does potentiate the kidney disease. How we prevent this whenever we start it for treatment is that we start at very low doses. And though in the acute phase it can increase your risk for AKIs, in the longer term, it actually decreases your risk of going to CKD because it helps the hemodynamics of the kidney. So, and also it helps secondary prevention in decreasing your risk for an MI or a stroke. Now, the other thing we do is statin therapy and antiplatelet therapy. Now, this is very typical for anybody with cardiovascular disease, and once again, this is helping prevent the risk for an MI or a stroke. Now, we talked about the bilateral and renal artery stenosis and unilateral renal artery stenosis. Let's talk about medications that cause prerenal AKIs due to selective hypoperfusion. We have a couple different here. So we have your ACEs and ARBs, your NSAIDs, cyclosporine, and SGLT2 inhibitors. Now, we did talk about SGLT2 inhibitors when we talked about it causing diuresis, but it also causes afferent vasoconstriction at the same time. And one thing we're going to notice whenever we talk about drug-induced causes, many drugs have multiple mechanisms. I would never put on an exam what is the primary mechanism of SGLT2 inhibitors, AKI, and give you both options because that just wouldn't be fair. Cyclosporine causes afferent and efferent constriction. And what cyclosporine is used for is for transplant. NSAIDs cause afferent constriction by blocking afferent dilation effects on the prostaglandins. So if you remember, the afferent arteriole, in response to low perfusion, releases prostaglandins, including PGE2, and what PGE2 does is cause vasodilation. When NSAIDs are given, it actually will cause this dilation not to occur and lead to more like vasoconstriction. On the other hand, we have ACEs and ARBs, which cause efferent dilation. And that's because, if you remember, AT2 causes vasoconstriction in order to maintain regular perfusion. And when you give an ACE inhibitor, it's going to actually cause this to dilate back out. So it's actually affecting our body's ability to maintain regular perfusion, and especially in times whenever our body is trying to compensate. Now you can see here cyclosporine works on both efferent and afferent constriction, and the SGLT2s work on the afferent arteriole. For each of our drug-induced causes, I do want you guys to know the mechanism, the risk factors, and the treatments. So risk factors are listed here. All these have very similar risk factors because in these cases, your body is already having some hypoperfusion, and so all these are risk factors that are similar, and then they can be potentiated by these drugs. For ACEs and ARBs, you also have bilateral renal artery stenosis, and then for cyclosporine, it is dose dependent and if you're on interacting medications, and that's where this G-Pacman comes in. So cyclosporine is a CYP3A4 substrate, and so the CYP3A4 inhibitors can actually increase concentrations, and the easy mnemonic to remember that, and this is something that they do whenever they're trying to get you prepped for the NAPLEX, is to remember G-Pacman, where G stands for grapefruit juice, P is for protease inhibitor, A is for azole antibiotics, the other A is for amiodarone, cimetidine is the C, macrolides is the M, and non-dihydropyridine calcium channel blockers is the N. And it is in your slides, it is in the module if you want to try to grab that without having to listen to me multiple times. For the treatment, so ACEs and ARBs can increase your serum creatinine. Once it gets to 1.5% above the baseline, so that actually should be 1.5 times above the baseline, that's when you should consider discontinuing therapy. If it's between 1.3 to 1.5, you can evaluate the risk versus benefit. NSAIDs, you should discontinue the medication, and if you do need to restart, start a lower dose. Cyclosporine, you reduce the dose or hold until the dose is normal. and restart at a lower dose, and then DC and interacting agents. And then for SGLT2 inhibitors, you shouldn't restart it until the eGFR is greater than 30. For all these, we do want to provide supportive care, so that would be fluids and ensuring that the patient has normal electrolytes. So let's look at this. So once we know that the patient has met the diagnostic criteria for an AKI, we'll perform a renal ultrasound. If there's any obstructions or anything like that, we will assume that it's post-renal. But if the kidneys are normal in ultrasound, we will calculate a FeNA. If the FeNA is less than 1, that's how we know it's pre-renal. And then if there is a medication-related cause, we want to discontinue it. If there's not a medication-related cause, we start thinking to ourselves, is there hypovolemia? Then we want to make sure that we have oral rehydration. If there's resistant hypertension, flash pulmonary edema, worsening because of an ACE inhibitor or an ARB, do blood pressure management and consider revascularization. Signs and septic shock, fluids plus or minus pressors. And then finally, if there's volume overloaded, give a loop diuretic. Next, we're going to talk about intrinsic AKIs.